You don't need more knowledge to become a better clinician. You just need to learn how to use what you already have consistently. Your MP Pal here. Welcome to another lesson from the track. All right, so today's segment I'm going to call How I Approach Every Patient, a simple framework. So over the years, working in ER and urgent care, I realized something. It wasn't that I needed more knowledge. I just needed to learn how to think through each patient. So going back to the beginning, get out of school, no transition period. We don't get a residency or even a preceptorship. School, you memorize facts to the real world. Then just throw you out there and you have to just figure it out. So of course, those first couple years are rough as you're trying to find your footing and how you basically do this and function in this role. So at the end of my first year, I had some confidence, and it wasn't that I felt smart, it was just I kind of figured out, I don't want to say how to practice, but how to manage and how to do this thing. So that helped me as far as how to get through it. So, and then with time, just working in different settings, moving around from ER to urgent care, doing primary care and things like that, definitely started to pick up patterns and things like that. So fast forward to me creating this platform, the URMP Pal. It started with something simple, and just as it evolved, I was able to kind of narrow things down to a simple framework. And it basically comes down to having a system and developing this framework, basically how to think through each case. And that's where the idea for Clear came from. So if you've been watching my videos, I've been talking about having a system and just knowing how to think through each patient. And it's something that you can literally, once you get it down, you can use it in just about every encounter. So let's get straight into it. All right, so the first letter in Clear is C. So that's when you collect the story. So again, if you've been watching my videos, I spent a lot of time talking about how the interview is the most important part, because that's where you're getting information. And so just recently, a few days ago, I posted a video about not to anchor on a diagnosis. Basically, you already kind of have an answer before you even walk into the room. You may read briefly through the HPI or whatever the tech has put in there, and you've already come to the conclusion. And then you go in there looking for ways to kind of confirm what you're already thinking. That's not how you want to do this. So you want to go in there with an open mind, even with the information that you've already had. Now, I worked in a bunch of clinics, and so I will say that not every technician, MA, whatever you want to call them, they're not all created equal. I mean, I've worked in some places where I've had some really good ones. They really get a very detailed history and a good story, and that way it does kind of help you some going into it. And there's like a paragraph. Or I worked in some places where you just get sick, arm pain, UTI, and you're like, wow, that's very helpful. Thank you for that information. So even with that, there have been studies that show that patients have maybe 3 or 4 versions of the story. So when they first walk in, whatever they tell the front desk, that may be one story. And then depending on the process, there's usually an MA that will bring them back and do a triage. They'll get another story. Depending on if you have a student, if you have somebody working with you, they may go in there and talk to them, and then by the time you get in there. So they may have told the story 3 or 4 times, and it may be a different story each time. And each level may get another layer of information. So let's take an MBA, for instance. So as far as collecting the data, right? You want to have an idea before you walk into the room, because your questions should kind of gear towards a particular diagnosis, or at least a differential list to build upon. So with an MBA, why is it important to ask certain questions as far as were you wearing a seatbelt? How fast were you going? Tell me about the actual wreck. Like, what happened? Did you rear end somebody? Did you get rear-ended? Was there a T-bone? What is that? Head-on collision. Were you on the highway? Were you on the main road? So all of these questions are important because they help you determine the mechanism of injury. So again, if it's something where it just happened maybe like an hour or so, and the patient is still a little anxious and a little worried, still kind of freaked out, especially if they may be at fault. Some patients may be a little defensive, but they'll say, "Oh, I don't remember," or they'll kind of get a little protective. Now, I've had that happen before, and what I found out is that some patients assume or think that you're gonna call and report. If I'm sensing that, or they get a little defensive or evasive and they don't want to answer the questions, I'll just tell them, look, this has nothing to do with insurance. I'm not gonna call anybody on you. I'm not gonna report anything, okay? So I just want to know what happened. That way I can help to evaluate your injuries. And usually they will accept that. Because I'm gonna tell you something like this. Working in the ER, and let's say it is their fault, I've had patients strapped to the backboard, C-collar, they're laying flat, can't move. And the cops come in there and this is your fault, right? Like they're talking to the patient I'm like, at least let them get out no. So I don't even get into all of that stuff. So that may be something that you're kind of sensing just during an MBA. But why these questions are important? Because again, it's different if it's a little fender bender. They were at stopped and the person behind them was going like 5, and then they hit them. Okay, yeah. Oh yeah, I'm a little sore here. Versus somebody going 60 and it's a head-on collision. So all of those questions are kind of gearing towards a particular diagnosis on the differential list, okay? So collect the data. Let them talk. Let them tell you. They may tell you way too much, but that's your job to filter through that and to remove things that may not even be important. A lot of patients, they like to give you information that they may feel, or another thing is that they've already come to a conclusion and they're only telling you certain situations. Or you got the patient that are just very short with you and you ask them questions. Oh yeah, oh it's just this. Oh yeah, cough too. So that's why I asked them, what is it that brought you in? You ask those open-ended questions like we learn in school, but tell me the story. And yes, there are gonna be patients that may give you a little pushback. Well, didn't you already read the chart? I already told this 2 times already. Like I always say, I'm the person that can do something about this. So let's hear it one more time. I wanna hear it from your mouth. Or you may say, they may have not collected all the information. They may not know all the questions to ask. So I need you to tell me one more time. So that way you can get the full story, okay? So that's the C, collecting the story, which is data collection, okay? So the next one is the L. So you look for red flags. And that kind of ties into the C because what you're trying to do essentially is cross the things off the list. So the things that are pretty bad, like if it is an MBA and you're worrying about a neck fracture, right? So again, asking those certain questions. How fast were you going? When you had a complete stop and they were going about 45, 50, you jerked forward, your airbags came out, you had LOC. Like all of those questions are important versus somebody who was just mildly rear-ended and they were gripping the steering wheel, the airbags did not come out, and now they have stiffness and things like that. Why? Because usually most people do grip the steering wheel, so it's not uncommon. Actually, a lot of the times with rear end injuries, they're gonna have neck and shoulder pain and things like that. So again, asking those questions because that's the purpose of a good interview, and it saves you time and helps to narrow things down very quickly, just asking certain questions. So you wanna look for those red flags early on and identify, is this something serious? Do I need to escalate this, okay? All right, so next letter is E. Establish the setting or the environment. Where are you when this is happening? Are you in a primary care office? Are you in urgent care? Is this the ER? So those places matter because that can determine what you can actually do in that moment. Primary care, you really don't have much. Like, I've worked in some places that they kind of function like an urgent care, so some have X-ray on site, but that is very rare. So usually you have nothing in the doctor's office to rule anything out. So a lot of times those patients are gonna get sent out. unless it's been like 3 or 4 days later and they're just sore, where it's something where you're just writing a prescription or something like that. So that's primary care. So urgent care, you have x-rays that are on site that you can use. With that, especially for spinal injuries, right? So common one that you'll see is neck pain or lower back pain, and the patients in their mind, they are thinking, oh yeah, let's get some x-rays to make sure nothing's going on. So I am trauma certified. I got my ATLS a couple years ago, and talking about the cervical spine, for instance, during that class, it was pretty cool because they were talking about the mechanism and the types of injuries and things like that, and how you actually roll out a fracture. But then they had a picture of an x-ray on beside the CT, and it was like night and day. So when I'm explaining to patients as far as getting neck x-rays, because they don't show much. Really, spinal x-rays at all, especially like lower back, they are really moving away from that, because that really does not tell you anything, okay? And most back injuries are musculoskeletal anyway. And I just remember working in the ER, and it was, I don't want to say forbidden, but they highly discouraged. And if somebody did order a lumbar x-ray, you probably had a meeting with the higher ups, at some point, or somebody said something to you about that. So, and it's not just following the rules, but they just don't show you much, okay? So if you are concerned about a true problem where, oh, this could be an actual spinal fracture, we're not looking for whiplash. We're not looking for that, because that's a clinical diagnosis, okay? So you can just tell if their head jerked back, which a lot of times that's gonna happen during an incident when somebody is rear-ended. Okay, it's gonna be stiffness. They're gonna have limited range of motion and things like that. But as far as an actual fracture, they're gonna have tenderness and limited rotations. So if it's to the point where they can't even really move past a certain degree, then yeah, the incidence is gonna go higher up. But again, going back to the C and the L, what happened with that wreck? So not just were you wearing a seatbelt, how fast were you going, what was the collision? Were you able to get out of the car by yourself, or did you have to be extracted? I also asked, did the police and EMS come to the scene, right? Because that'll give you a picture of the scene itself. Did you have to get help, or were you able to get out? Did you hit your head? Did you black out? All of those questions are important. Now, I've had patients that they did have LOC. They did need assistance, and they got checked out, and they felt fine after, and there was a recommendation to be taken to the hospital. A lot of people refuse because they don't want to pay that bill. Now, they should have gone. But I will say, most of the ones you're gonna see, especially in urgent care, they usually walkie-talkie. And I can maybe count on one hand as far as me having to actually send somebody to the hospital after a really bad wreck. Because if it's that bad, they usually go to the hospital or they're taken from the scene, okay? So the majority of the ones that walk in, they get out and things like that, you can usually safely discharge, okay? All right, so again, with the whole, what can you do in this setting? Patients will push for x-rays a lot of times for spinal. If you do end up doing it, it's just more for reassurance. And sometimes I will do it, but I do try to talk them out, especially for like the neck and stuff like that. I'll tell them, I'm like, listen, a neck x-ray is kind of pointless. It doesn't give us a whole lot of information. This is why we even do that in the first place. And then I'll tell them about the CT, and they will usually accept that in the majority of the cases. Some patients, they will kind of push you. They say, oh, for insurance, and sometimes they need to build a case, and so they want some things documented, which, all right, in that case, I'll order it, but I'll tell them, I don't think we need to do this. I don't have any suspicion for a fracture, but for documentation purposes, okay. kind of like a workers' comp injury where you just do certain things just to just for documentation, okay? All right, so the next is the A. So act on the best decision. So you got your story, you got your red flags if you have any. If not, you cross them off the list and you know where you are. So with that, what do? Okay, so that's when you make your determination. Is this something where I need to send you out? Do I need to do testing? Do I need to set you up with a referral or something like that? So that's basically the part where you actually make the determination, okay? So again, a lot of providers will just automatically decide before they go into the room. And that, it's not good for the patient because a lot of times you miss something. Or if it's something where you've seen it over and over, you heard the story and things like that, and you just, oh yeah, I know what this is. And you already locked on and you're not even listening. And that can be very frustrating because I've known a lot of providers with terrible bedside manners where patients will actually come and complain and things like that, okay? So you don't want to be that person, all right? And then the R is route the patient safely. Where do they need to go from here? All right, is this a safe discharge? Is this, you probably need to go to the hospital? Or is this, I'm gonna set you up with a follow-up, you need a referral to specialist or something like that, okay? I just use the MBA as an example, but if it's something where you're unable to truly rule things out and it's not an emergency, that's usually where the referrals come in, okay? And so again, referrals are great. You can always put them in, you can submit them, things like that, okay? And that's pretty much it. So I use this because it is a framework that you can apply to every single patient that comes through, okay? And it decreases your stress and anxiety, and it's all about clarity. Like, how can I simplify this process without spending too much time? And that's pretty much the process I've used for years. I just didn't have a name for it. It wasn't so narrowed down and specific, but I'm glad that I did figure out, and now I'm able to share it with you. All right, so I put out content every week, and if you like what you heard today, hit the like button and subscribe, and I will continue to put these out. And I'm hoping to give as much information as I can from some wisdom from the journey that I've been on. It's been 9 years now, and it's been quite a journey, I will say that. So that's the whole purpose of this platform, is to educate you. I'm the friend that has been out here working, and I've seen a lot, and I want to help save you time and years and stress and things like that. So that's my goal here for this channel. So again, if you like what you hear, subscribe. As always, think clearly, practice boldly, and I will see you on the next one.